Yeah, good morning. Thank you for being here. It's my pleasure to introduce Dr. Cannon to present pediatric grand round for this year. Dr. Cannon is a graduate from UW for her medical school, and then she did her residency as well as her fellowship in Seattle. And she had been appointed as the director of DEI at the department. And she had been very active, actually, to really look at all the different layers of healthcare delivery and patients in the pediatric population as well as in the adult. She's very active in the Pediatric Society of Pediatric Urology, as well as other societies for the urology, women's in urology too. So it's my pleasure to introduce her, and please, thank you.
All right, thank you for that introduction. I'm going to have a hard time working this little microphone moving around, so I might stand behind this podium, but thank you for your attention today. And I'm going to be speaking about pediatric spina bifida care and disparities in that care. So I'll be reviewing the current literature about disparities in care access, management, and outcomes in spina bifida. And then we'll talk about the impact of those disparities on quality of life and health outcomes. And then finally, we'll be looking at a few strategies to eliminate disparities for patients with spina bifida. And I want to start off by saying that this talk has a really wide breadth of research that I'll be highlighting for you today, because there's not a lot of depth in this field. There's a lot of people doing kind of preliminary investigations into disparities in care. There's not a lot of deep dives. So you'll be seeing kind of a wide spectrum of looks at how disparities affect care access, management, and outcomes. So first of all, spina bifida is complex. And so that's part of the likely reason why that it is very challenging to study all of the ways that access and outcomes are affected by disparities over time in an individual patient and in populations. And that's because not only is it a single disease, it's, really there's several different components that are affected in the individual patient, and then several different considerations that need to be accounted for when thinking about caring for a patient with spina bifida. And these change over time as well. So, when we think about the prenatal time period, we're thinking about, early diagnosis of spina bifida rather than a surprise diagnosis with birth. And, I'll talk about this a little bit more in detail, but, doing a repair of myelomeningocele prenatally is really kind of emerging as one of the major issues when it comes to access to care. When we think about, moving on to infancy, we're really thinking about ensuring that if the patient has not already received a repair, that they receive one in a timely fashion. And then also that we're making sure that their renal protection is accounted for and that we've reduced the risk of UTIs. And while those, kind of two main important features of urologic care for patients with spina bifida, renal protection and UTI prevention, are still really, big considerations for patients in childhood, then we start to think about achieving continence. And as they move on to adolescence, that continence piece also then moves into independence with managing their bowel and bladder continence, and also thinking about transitioning into adult care. And then when we see patients with, adult patients with spina bifida, we start to think about, how are they directing their care? They moving in that transitional period from being cared for by their parent or caregiver to someone who is managing their own care, who is seeking out what they need from a medical standpoint. And then also thinking about surveillance and screening, especially for patients who've had major reconstructions, thinking about, how they're going to interface with urologic caregiver or providers, but then also thinking about other kind of surveillance components of their preventive care, especially as people are living longer with spina bifida. And then you see down here, it's not just urologic care that we're thinking about for these patients. There's actually a really wide variety of things that they need. And this, represents a multidisciplinary group of clinicians and providers that help ensure that patients have health for an extended period of time and also quality of life. And so interfacing with, all these groups and thinking about all these things are really critical to making sure that patients have high quality of life and, longevity. So, when we think about all of those things that play into, what spina bifida care looks like, that means that there's many contributing factors to disparities in access, disparities in management, and in outcomes ultimately. And these are all interrelated. So they're very hard to parse out and disentangle from one another when we're thinking about disparities. And so that is what makes this so challenging to study. So, some of the considerations that have been studied, and again, hard to disentangle, but, things that we think about are, I think first and foremost, clinical features within the individual patient. So that'd be myelomeningocele level, whether or not the patient is ambulatory, whether or not they have hydrocephalus and had a need to be shunted. But then we also think about some of these other issues that oftentimes we don't really think about when the patient's sitting right in front of us in the clinical space, and that's, geographic distance from their care, the finances that are required to actually receive care, that would be time off from work, the time or the money it takes to actually get to the hospital, child care for other children, and then health literacy, both for caregivers and the patient, insurance status, that can certainly play an effect, especially as patients move on to adult care. Language, and how they interact with the healthcare community, and their education level, both for the caregiver and the patient, as well as some of these other kind of demographic components. And I think one thing for patients that is really, pediatric patients that's really critical is family stability. And I think that is something that is really hard to measure, but is also critical for, whether or not a patient is able to, follow up regularly, adhere to treatment plans, and have good outcomes. So when we look at access to care, I think this starts from the very beginning. It actually starts from before the patient is born. So, historically, and even currently, I would say that the approach to repair is in the immediate postnatal period, so shortly after birth. And, I'd say it's the gold standard, but, there is emerging data that prenatal repair has significant benefits to the patient. And so this is the New England Journal of Medicine paper from 2011. This is the MOMS trial, or Management of Myelomeningocele Study. And this was a randomized trial of patients undergoing prenatal versus postnatal repair. So how does prenatal repair work? This is actually the diagram from this article. So the mother comes in usually in the late second trimester to very early first trimester, or sorry, very early third trimester, and has a low transverse incision, essentially a C-section incision. The fetus is manipulated so that in the myotomy of the uterus, they have exposed the myelomeningocele, and then they perform the same repair that would be performed in the postnatal period, except it's performed obviously much earlier in development. And this has been shown to really improve neonatal and long-term outcomes. So when they looked at this trial, they saw that there was a decreased need for shunt, so a decreased level of hydrocephalus among these patients, and then improved mobility up to their 30-month follow-up. And that actually extended beyond. So there was a second kind of follow-up study of these same patients that looked at them 5 to 10 years later and saw that there was ongoing improvement in these outcomes. No improvement, unfortunately, in urologic outcomes, but I think it's, it's without question that these additional issues, the need for shunting and the mobility status, affect all components of these patients' care. But at the same time, these patients need access to a fetal surgery center. So, the MOMS trial was started in a handful of places. And currently, where do fetal surgeries take place specifically for myelomeningocele repair? Well, it's at, basically a handful of places across the country. And this is the most current map of fetal surgery centers where this is performed in this country. So not that many places. And if you look at, kind of the upper western half of the country, there's literally nowhere that people are, flying to these centers for this care. When they looked at one center, this is actually at UNC in Chapel Hill in North Carolina, and they looked at the patients who were receiving fetal repair to try to understand what were the demographics of patients who underwent prenatal versus postnatal care. And they had a total of 96 patients who were seen at UNC, and 36 underwent prenatal repair. And they looked at the people who did not get prenatal repair, and they saw that an additional 19 patients were eligible for prenatal surgery, but either they went to seek treatment elsewhere or they chose not to have the prenatal surgery. And they didn't give reasons for why that was. But when they looked at their overall population, they saw that of the patients in that 96 who were evaluated, 70% were non-Hispanic white, and 75% who underwent the surgery, the prenatal surgery, were non-Hispanic white. So a higher proportion of patients who were white were undergoing the prenatal surgery. And that's compared to the overall demographics of children who are born in North Carolina, much lower than the group that was seen at UNC in the first place. And really, when they looked at some of the demographics of this population, they saw that a really low percentage compared to the overall percentage of patients in North Carolina were uninsured. So likely representing, a higher socioeconomic status population who was being seen in the first place at UNC for care. And when they looked at, they tried to use an index of distress in the community. So this is the Distress Communities Index. There's various indexes that look at socioeconomic disadvantage or need. And this one, they showed that basically patients who underwent fetal repair were from much lower distress communities. So that really indicates, kind of the similar findings of those who were being seen at UNC were higher level of insurance rate, likely from higher socioeconomic backgrounds. When a group at Cincinnati Children's tried to understand why, what influenced the decision to choose prenatal versus postnatal repair, really a lot of it was related to some of those geographic and financial considerations that I highlighted before. So, what do parents do with their other children when they are going to a fetal center? What does it cost to actually be at that fetal center for the time period of undergoing surgery and then recovering from that surgery? And then how much does it cost to get there? When we look at postnatal repair, there is also kind of measures of quality and of access, and that's really understanding that postnatal repair happens shortly after birth, and so that's within 2 days of birth is considered timely surgery. And when patients are born at lower level nurseries, that is less likely to happen. So patients who are born at hospitals with lower levels of care have to travel, most likely to a site where there is a neurosurgeon or a pediatric neurosurgeon available. And we see that timeliness factor is decreased for patients who are publicly insured. And then also for patients who have a higher acuity at the time of birth. So if they're born with low birth weight, or if they're born with hydrocephalus, then oftentimes there's some stabilization factors that need to take place during that time. But that highlights that, there is a time period in infancy where patients and families are really thinking about their travel needs and the finances that come with it. So in not just related to repair, but then in the time period in the first year of life, there are a lot of visits for these patients and their families. So, there are higher costs associated with that, going to the clinic more often. And then when we think about that, we think about each time they're traveling, how far they have to travel. So this is a study in Florida of patients who were born with spina bifida, and looking at maternal residential address. You can see here that this slide shows the state of Florida up in like figure A, where there are these little circle dots, and those are where the mothers live in the state of Florida. These are where the centers are where patients could receive care for spina bifida. And then these lines here represent, as the crow flies, distances that patients were traveling from their homes to the centers where they received care. We saw that patients who had complex spina bifida, that's often associated with a higher level of acuity, and hydrocephalus, again, likely need for shunting and higher level of acuity. They were more likely to travel more than 30 minutes for care. Whereas patients who were born from non-white mothers were actually less likely to travel long distances for care, and that was concluded by the study that it was likely due to the fact that they were living in urban cores. But that highlights not just perhaps racial, ethnic, and socioeconomic disparities, but also geographic disparities, likely rural patients traveling very far distances to receive their care. And then I highlight this figure just to show all of the potential cost drivers and financial distress pressure points for patients over the entire care process. It's not just about getting to clinic. It's not just about the patient or familial factors, but it's also things like, catheter costs, whether or not they have insurance. If they're underinsured, how are they going to pay the bills? Do they have to adjust their work? Is their work going to be tolerant of that sort of adjustment? And what does that do to their family life at home? And so all of these things play into kind of the financial toxicity that families and patients experience with this disease. So I'm very briefly, unfortunately, going to touch on urologic outcomes, because there's actually not a lot of data on how disparities affect outcomes. Most of these are looking at large administrative databases. So there was a group of researchers that looked at the National Spina Bifida Registry from 2009 to 2013, and they looked at measures of continence, both for urine and stool, and then they looked at the number of continence surgeries that were performed. And they saw that, when they defined continence from a urinary standpoint as dry, completely dry during the day, and bowel continence as no stool leakage during the day, they saw that there was a lower rate of continence and continence surgeries among Hispanic and Latino patients. But again, that goes back to the fact that there was a higher rate of non-insured or underinsured Hispanic and Latino patients compared to the general population. When they looked at these, from a standpoint of satisfaction, I would say, again, we see that there is a lower rate of continence. So this bar here shows a really high rate of incontinence from both a bowel and bladder standpoint among Hispanic patients. And then when we look at satisfaction, much fewer patients are satisfied with their level of continence. So it's not, that fewer patients are continent and they're fine with it. It's that fewer patients are continent and they would like for that to change. When we looked at we being urologists, not me, looked at the national inpatient sample from 1998 to 2014, they saw increased length of stay and costs for encounters among Hispanic patients. And they didn't explore much of the kind of underlying contributing factors that played into this. They didn't look at pre-surgical risk, cultural factors, geographic or population density cost differences. And they also noted that when they were looking at this data, there was significant coding construct flaws for coding race and ethnicity in the national inpatient sample. And I would just say that because there's a lot of literature outside of spina bifida in both adult and pediatric literature in urology that relies heavily on administrative data, relies on the national inpatient sample. It's a pretty highly utilized H-cup database. And the researchers who wrote this paper concluded hopefully future analyses will be able to avoid NIS's reliance on white race as a de facto comparator, and instead adopt a more nuanced approach to a very complex research topic. So even these authors who were researching this using an administrative database saw the flaws in approaching it in this manner. When we think about other considerations, we think about quality of life. I think that's really a big one, and that gets back to the idea of, when we looked at patients being incontinent, they're likely to be not satisfied with that. So when we think about how continence outcomes play into quality of life, we also think about, how that affects every other component of patients' and families' life. So we see that household income and family functional status are strongly associated with health-related quality of life, and it's a predictor of psychosocial functioning for the patient. When a group of researchers looked at quality of life concerns in their patients, they saw that family status was somewhat of essentially like an effect modifier for patients who were from a Latino or Hispanic background, and that their kind of overall psychosocial functioning outside the home was impacted more significantly by their family status, either family conflict or family cohesion. And that, I think really concludes for us that we need to be mindful of patients' family structures when we're thinking about how they interface with healthcare, and that in certain cultures, family structure is actually very critical to overall health related quality of life. Health literacy is another significant impactor on the outcomes for patients that we see, and we don't often spend time measuring. So this group of researchers measured health literacy using 2 scoring systems, and I highlight the newest vital sign. This is one that I'll refer back to in a little bit. They looked at catheterization compliance among patients who had spina bifida, and they saw that those with lower health literacy had decreased adherence. So this group of 4 to 6 times or 7 or more times of missed catheterizations per week had lower health literacy scores. And overall, health quality of life is associated with increased health literacy. But when you actually look at the overall population of patients with spina bifida, over 50% of them have inadequate or marginal health literacy levels. And so that really tells us that, there's a sizable population of patients who have spina bifida, who have low health literacy and likely have impacts on their quality of life as a result. Caregivers do play a role for pediatric patients in health quality of life, but I think this is something that we really have to focus on as patients are coming up for transition, because when you see these numbers, you recognize that these patients have low health literacy and really will need some additional tools to help them navigate the healthcare system. So when a group looked at caregiver health literacy, they did not see significant difference between caregivers who had patients with spina bifida versus control caregivers. But when they looked at a group of healthy adolescents, obviously these were dyads, caregivers, and adolescents. When they looked at healthy adolescents, you see kind of what looks to be a normal distribution of health literacy, significantly increased limited health literacy among spina bifida patients. And then when we think about cost of care, we think about, how much money is being spent by not just the healthcare system, but the patients and their families when they're undergoing this care. So like I said earlier in this talk, infant care is very expensive because it's a really high frequency interface time for these patients and families. And we looked at, for infants, that there's a mean of 2.4 hospitalizations in the first year of life. That's, I'd say that most families out there, their children are not going to the hospital at all in the first year of life. Most families may go to the emergency room once in the first year of life. And these hospitalizations are oftentimes lengthy and costly. So, a $39,000 hospital stay in 2011 or nearly $60,000 in 2003, or 2023, that's a long hospital stay, or it's a high acuity hospital stay. After infancy, we see a decrease because, again, that kind of time period of frequent interface decreases a little bit. But the annual costs still remain fairly high. So $15,000 a year in 2003 translates to about $25,000 a year in 2023. And that doesn't get into the other components of healthcare utilization, like prescriptions and DME. So catheters are a big component of that for many of our patients. And I take that all back to the very beginning when we think about patients who have had a prenatal repair, who have improved ambulation, who may not need as much in terms of orthotics, who may not need as much in terms of physical therapy, who are not shunted. Those all have an impact in their care moving forward and the cost for that care. So I wanted to do just a very, very brief, shallow dive into what our patient population looks like here at UW. So this is my reminder to say that this is a bird's eye view. And when I say bird's eye view, I mean I took it from Slicer Dicer, which is not the most granular of data collection. So, first of all, I looked at our patient list, which is kind of a self-made patient list. It's formulated by, we have some great nurses that I think Dr. Sue actually highlighted when she gave a talk last year about the setup of our Spina Bifida clinic. So we have about 191 active patients in our clinic right now. And this essentially amounts to like just a handful more. So it was about 217 that were included in this look. This is patients under 18 who have the diagnosis of spina bifida in our system. And we have, a mostly white population, if you look at race, with a small number of a wide variety of other races, Black, Asian, a few declined to answer, American Indian or Alaska Native, and then some kind of less frequent or unknown. And then we have mostly English speakers. So, I don't know how accurate this is because I feel like I see more patients who are non-English speaking. So, this is something that we'll have to do a little bit more investigation into. But then when we look at payer type, I found this to be very interesting. And I think this is something that we will definitely need to investigate further. But of the roughly 220 patients that were included in this, there was about 43 that were on Medicaid. We had, kind of a group that presumably had some sort of, private insurance. And then we had a lot of people who were self-pay. And I find that very hard to believe. That's a really high number for a self-pay group. But if that is the case, that's shocking and dismaying. And for those patients, that's extremely expensive because where we're providing our spina bifida care is right here in the hospital, which is a very expensive place to receive care. And just for, I guess, residents, medical students, why is that an expensive place to receive care? Because there's facility fees associated with everything that we do here. And then when we look at where our patients are coming from, most are coming from a metropolitan area. So this group here is metropolitan area core. That's kind of like a core metro area high commuting. That means that you live very close to a metro area, essentially like you're doing most of your daily activities in that metro area. And then we have, a sizable number who are in smaller locations. This doesn't get to how far they have to travel. I think one of the things about UW is that we don't have a really large metro area when you're thinking in like miles distance. So for a patient who is in a small town core, they may be traveling actually quite a far distance to get to our clinic. But this left me with more questions. Who are these all of our patients? Is this a true representation of all of our patients in our clinic? and in the state of Wisconsin? Are we missing some patients there? Are there patients in Wisconsin who aren't being seen either here or at MCW, which are kind of like the centers for spina bifida care here? Are they going to other states? Or are they not receiving care at a multidisciplinary center? Are they receiving care in a piecemeal fashion? So that really leads to that question, who are we missing and how can we reach them? So just to end here on kind of a, somewhat positive note, how to reduce disparities, especially since I highlighted a lot of things that maybe are a little discouraging. I'd start with kind of what I think needs to be done overall, especially just in light of what I've shown you. And that's really studying granular patient and family experiences rather than trying to look at large groups, because I think we miss a lot of what patients and families are experiencing in their pathway to care with us. We need to include diverse patient populations in studies. And I think that goes back to the idea of, if we're studying patients who are receiving, low, low resource things, prenatal repair at a high access threshold, then we probably are missing a large number of patients who may benefit from involvement in study and also access to those care tools. And when I say avoid race as risk factor, that gets back to the idea that, this is the studies that I've shown you that have looked at racial and ethnic disparities really are not getting to the deepest level of what is causing those disparities. That's really a proxy for many other factors, and I think that we need to get to those factors rather than using the data that's available in sometimes poorly coded administrative databases. And then, when we think about clinical work, can we do? I think we do some of that right here already, which is really providing guideline aware, culturally sensitive care. I think we can do more on that in that regard. We need to emphasize the services that help improve access to care and health literacy and family functioning, because we can see that those have significant impact on our patients. And we need to do more to evaluate the experience that patients and their families have receiving care at our center so that we can feed that back and actually improve the care that we give. So there are a couple of online resources that I just highlight here. These are really to focus on the guidelines. So the Spina Bifida Association, generates guidelines, so many guidelines in like every aspect of spina bifida care. And that helps to provide roadmaps to every specialty that's involved in these patients' care. And I'd really recommend that you go take a look at them if you're at all interested in this work. And then finally, the Spina Bifida registry, I kind of referred to previously, is kind of a collection of centers that all provide multidisciplinary spina bifida care. And the CDC has partnered with many of these centers to create a protocol. And, Dr. Bhatia spoke about this last week when she was talking about, standardization of care and how that affects urodynamic study. But overall, this group, the Umpire group, came together to identify how they can provide high surveillance, high prevention level care. How can we really get to the heart of renal protection for patients and identify the patients who need aggressive early intervention? And so this was from their initial proposal, but really has been adopted in many of the spina bifida centers as kind of a practice protocol for how often to get imaging, how often to check for renal function decline. And applying this across our patient population helps ensure that we have a really strong interface with patients who may be otherwise being lost and slipping between the cracks. And lastly, I'd say this is what happens when you involve families in care. And this is a very, very small example of what the possibilities are when you actually involve patients and families in care. So this was a group that was looking to create like informational handouts and a website for the Spina Bifida Association. And so they worked with a medical illustrator to come up with this little illustration. And they gave this illustration to some patients and families to look at. And they gave them these two options. And they said, well, every single patient here has an assistive device. They're either, using some sort of ambulatory assistive device or they're using a wheelchair. And that's not really accurate. Some people with spina bifida are ambulatory. Can you please include those people? And also, there's a lot of people with spina bifida who have some additional weight. So they have a larger body habitus because of some of their ambulatory limitations. And so they asked to have patients who looked more like them. And they went through this process again. They had patients and families sit down and really talk about what they'd like to see. They wanted to see, a larger number of patients who were, brown toned skin, because there's a large number of Hispanic populations who are more affected by spina bifida. And ultimately, they came to this final illustration, which was an iterative process. And this was an iterative process just to make an illustration. So it's a lot of work to make an illustration, but I think that this is the type of process that needs to take place to help identify what we can be doing for families that aren't accessing our services or struggling to access our services, and how we can provide better care for our patients. So with that, I'll close and take some time for questions. Thank you.
I do have a question. I'm going to first thank you for presenting. One question is related to the fact that I am a believer that the insurance, at least in this part of the world, is the major player in healthcare delivery. And, a lot of people like to avoid being confrontationalist and say this in loud voices, but did you come across any study that shows that delivery of care in universal healthcare like Canada or Scandinavian countries is better than the US? That's one. Two, do you really think that health literacy, or do you believe that health literacy is the most common reason for healthcare diversity or impact on diversity?
Yeah, I think that it's interesting because there's actually not a lot of research in disparities in care in nations that have universal health care. There's not as much, at least. And I think that probably speaks to two things. A lot of countries in Europe that have universal health care do not have as disparate of a population, although that's changing with time. But also, I think that a lot of what we're looking at with many of these papers is the insurance status being, a critical component for disparate access to care, disparate outcomes. So I do think that is a significant impact for our patients here compared to a country that has universal health care. And then, I think I can't remember what your second question was.
Just the question is about healthcare, health literacy.
Literacy, yes. So, I think that it is a very critical component. I think that probably insurance and health literacy are at the top. But at the same time, I think that some of the measures that are being utilized with increasing frequency now are kind of these measures of socioeconomic distress, socioeconomic disadvantage. They take into consideration many different components that include things like health literacy in, for instance, health literacy in an area, meaning if you come from a neighborhood where there's low health literacy, statistically speaking, you are likely to have low health literacy. It's very hard to study that, on a large group, in a large group fashion without doing some high cost assessments, meaning asking thousands of people for their health literacy is really not feasible. But if you're using a proxy index that is based on neighborhood or location, that can be a really good tool to use to evaluate health literacy, and some additional components that play into what we would call like disadvantage or distress. And I would say that because health literacy usually is correlated, at least somewhat, with education level overall, and that is correlated with financial mobility. That's also correlated with, all of these outcomes that we see regarding poverty, like health, like general health, chronic health issues. So, I mean, I think this is all very interrelated, and so some of those indices can be helpful.
Before we take more questions, I just want to add one other thing that it might be more of an idea rather than a question. I still insist that if you want to take this concept or subject to the next level, I would ask you to put in a ticket to Epic to provide you with the monthly data on all the spina bifida patients and study them longitudinally. I am so keen to actually to advise people to look at healthcare delivery in this population before the Health Act, the Obamacare, as they call it, and after.
Right.
None of that came out from delivering care to patients with no insurance. And I would be very much interested to see if you can actually show in Wisconsin at the Children's Hospital between 2010 and 2024, we had a difference in the healthcare delivery, at least based on the AHA. Thank you. Questions?
Dr. Cannon, great talk. I'm going to make a couple comments, and I promise it'll lead to a question. But I just want to speak to a little bit of my experience and like challenges with working with these patients in a rural location before I came here in Marshfield. And you mentioned in your talk that, are there patients out in the state of Wisconsin that we are not reaching at academic institutions? And the answer is definitely yes. There's probably at least 50 patients up there that I was caring for before. And the differences between that patient population and like where I trained, for example, at Nationwide is striking. Almost everybody has Medicaid. Everybody is traveling a long distance to see you. Most patients have extreme difficulty with compliance, with getting catheter supplies, everything like that. And so it's a very challenging patient to care for. And then to add to that, as a physician, I wanted to deliver high quality care to these patients, but often run into barriers with limited resources and things like that. And so my question for you is, in the state of Wisconsin, we have so many rural patients. What can we do, to help these rural patients? Because they don't want to travel. So trying to get them to come to someplace even like Madison or Milwaukee for other things is extremely challenging. So any advice?
Yeah, I mean, I think, obviously telemedicine can be helpful in some settings to touch base with patients, but I think it would be nice. It would be interesting to see how it could potentially play out to have like care plans kind of in the same vein that, like oncologists will function. So you may have a patient who is really far flung and is able to go to a local center for kind of more chronic care that has been mapped out by a center of excellence. And I think that would be a really interesting way to think about how you could have someone receive care very close to home, but have that person touch base with the kind of mothership, care center to say, here's how things have been going, and here's what I'm concerned about. And then be very selective with the time periods that the patient goes to the main center for care. And I mean, that's just one idea. And I don't think that anyone's actually posed this in the literature in terms of like, what could we do? How could we achieve a structure? How could we, actually execute a structure that would be functional for patients in rural areas? It's really understudied.
Yeah, I think in an ideal world, that sounds amazing. I think the challenge is attracting individuals to these rural locations to care for patients. Like, for example, now that I'm gone, there's nobody who's really doing it. So just food for thought, I think it's a very challenging issue.
If you allow me to, sorry, Dr. McCacken, go ahead. I was going to add something to this.
Just a quick question and comment. Fantastic talk. Thank you, Shannon, as always. One of the AUA's public policy initiatives right now is rural medicine and increasing urologic care to rural communities. And as part, and so, there are lots of programs for primary care where you have debt relief and other things, but we don't really have those for surgical subspecialties. And so that is a program that the AUA and the AUA PAC is sponsoring. But I think along with that, that means that urology programs need to continue to provide really broad training to these folks who are going out to rural areas. So peds and female urology, because these are big issues that affect a wide swath of the population that folks can't travel for. So I think training people broadly to be that local touchstone is beneficial in our current healthcare delivery structure.
Yeah, to add to this, by the way, I do really think that between telehealth and telemedicine, as well as having people to deliver care the untraditional way, people, the 2023 and on, we're not going to have people actually come to the hospital. And UW championed some new form of home care for older people, that you go home and take care of them. And I can't imagine that this would not be an innovative way to deliver care, where you have non-operative pediatricians go to different areas in Wisconsin, rural areas, and just care for the medical aspect, and the surgery will be done centrally. This would be a good way of doing it. I know that this had been happening in Canada, at least.
Yeah, thanks, Shannon, over here. Yeah, we're all trying to identify sort of low-hanging fruit, when it comes to approaching this problem. And thank you for the talk. A question about maternal access to care, since a lot of spina bifida is potentially related to that, prenatal vitamins. One question is, there's a difference in as far as can you trace it back to education or insurance as far as rates of spina bifida? And again, when you think of something easy to do, that's prenatal vitamins are important.
Yeah, I mean, I think, there's the frequency of spina bifida births has stabilized somewhat with the addition, like the enrichment of many grains with folic acid or folate. And there's a sizable amount of literature that came from the neurosurgery literature on their active role in trying to advocate for the enrichment of rice with folate, because that was actually that's a staple dietary component for like Hispanic culture. And that was something that if it was not being enriched, that was being consumed and actually increasing that likelihood of spina bifida. But since the enrichment push has taken place, and I would say like the vast majority of rice in this country is enriched now, that has stabilized, there are certainly hereditary components to spina bifida, and that's why we see, families that have multiple children with spina bifida. It's, there's obviously some components that are genetic, but I think that prenatal care is really the key component at this point, and the push to have patients, take folate supplementation. But it's I don't have any good answers. I think I have the knowledge of what has been done so far, but I don't know what the next steps should be in that front. But I do know that, obviously there's a whole kind of area of advocacy for maternal health and access to prenatal health care, because we have a really high rate of infant mortality at baseline in this country for a developed country. It's not really acceptable. And so this plays into that as well.
Dr. Cannon, just a wonderful talk. I'm really fascinated by this idea of family dynamics, structure, and literacy. Who is the group that helps design supportive interventions for that? Is it social work? Is it psychology? Because I feel like that's something I see play out in almost every clinic visit.
Yeah. I think I think that there should be more involvement with psychology with our patients. And that's, family therapy, that's patient therapy. And unfortunately, when we're seeing families, we are not seeing the parents or caregivers as patients, right? And so our push to kind of plug patients in with psychology may not reach all of the people who need to have some sort of work on cohesion, work on coping, and that sort of, work on management of stressors. And so, yeah, I do think that psychology would be a great resource if we were able to structure it. And I think one of the structure limitations is like, how do we pay for it? How do we bill for it? Like, who's going to manage this financially? Are we liable, like, for referring people who are not our patients? There's just so many of these limitations that we encounter. I mean, we encounter them just trying to get psychology for our patients. And when you start thinking about getting them for whole families, that's challenging as well.
The NIH has a push right now for mobile mental health interventions, or mHealth. So I think this could be a really cool place for us to think of some things offline.
I like it. All right. Well, thank you, everyone.